Hello again. This is Dr. Debbie Morris, and we have come to the second part of our respiratory physiology lecture. So, in the first part, we talked about anatomy and we talked about volumes and structure of the lung and a little bit about function of the lung. In this lecture, we're going to continue to talk about breathing, about the function of the lungs as a pump and the pressures that drive inspiration and expiration. We're also going to talk about control of breathing, and at the very end, just touch on a couple of medical conditions that involve the lungs and the ventilatory system. So I want to start by talking about the mechanics of breathing. The lungs are kind of like a bellows, right? They're a pump, and they are powered, this pump, by muscles, and some very specific muscles, and we'll talk about those. The contraction and relaxation of muscles causes changes in pressure within the thoracic space that allows air to be moved in and out of the alveoli, in allowing for oxygenated air to come into the alveoli and gas exchange to occur, and the less oxygenated air to be expelled with its load of carbon dioxide. The primary muscle of breathing is the diaphragm, and the diaphragm is what drives inspiration. There are other muscles that are recruited when we need them. So, when we are exercising and need to breathe more, we recruit the internal intercostal muscles and some other accessory muscles, mainly of the neck, to help us better inspire. Expiration is primarily from relaxation of the diaphragm, along with something called elastic recoil of both the lungs, which have a lot of elasticity and want to return to a smaller size, and the rib cage, which has been expanded during inspiration. So when we relax the diaphragm, the expansion of the rib cage recoils and air is pushed out of the lungs. But again, when we're exercising and in certain obstructive lung diseases, and the two that you will encounter most commonly are asthma and chronic obstructive pulmonary disease, COPD, which consists of emphysema and chronic bronchitis. And in those conditions, we use additional muscles to assist expiration. And those muscles are the internal intercostals and the abdominal muscles. And here we have a really nice diagram of the muscles of inspiration that is showing the direction that they contract in and how that might affect inspiration and expiration. So these are the muscles, the principal muscles of inspiration are the diaphragm, which is a dome-like muscle sitting here at the base of the lungs. And when it contracts, it basically decreases pressure and pulls air in. In addition, the external intercostal muscles elevate the ribs, again decreasing pressures and pulling air in. And finally, what we call the accessory muscles, which include the sternocleidomastoid and the scalenes, pull up on the sternum and on the upper ribs and the clavicle. Again, kind of further decreasing pressure in this intrathoracic space, allowing air to be inhaled. The muscles of expiration, under normal circumstances with quiet breathing when we're at rest, there is very little muscular activity. The diaphragm relaxes, the lung elasticity causes them to get smaller, the rib cage relaxes, and all of those things increase pressure in the intrathoracic cavity, causing air to be pushed out of the lungs. But when we're active, when we're exercising, when we are talking, when we are working harder to breathe, and also, as we mentioned, with certain obstructive lung diseases, other muscles get recruited. And they include the internal intercostals that pull the ribs down, the abdominal muscles that both pull the ribs down but also compress the diaphragm, basically compress the stomach contents, which pushes up on the diaphragm. And then also the quadratus lumborum, which pulls ribs down. So if we pull the ribs up here, we are expanding the thoracic cavity, and when we pull the ribs down, we're shrinking it. So that's why these muscles that pull up on the ribs, pull up on the sternum and the clavicle and the upper ribs, cause expansion of the intrathoracic space, decreased pressures, and inspiration, along with the contraction of the diaphragm. Diaphragm relaxation, elastic recoil of the lung tissue and of the rib cage cause expiration, with assistance when necessary from these muscles that pull down on the ribs, these muscles that both pull down on the ribs and compress the abdominal contents, pushing up on the diaphragm. And all of that increases intrathoracic pressure and pushes air out. So let's just go through those and talk a little bit about the pressures. If you are sitting at rest with your glottis open, so you don't have a closed glottis, you have an open glottis and you are not breathing, so like this, the pressures in your airways are the same as the pressures in the room, and we're going to call that zero. So pressures are equal, and there is no difference in pressure between the inside of the thoracic cavity and the environment. But when you begin to inspire, your diaphragm contracts, and as it contracts, it flattens and it increases the space in the intrathoracic cavity. And that decreases the pressure in that cavity. The diaphragm is innervated by the phrenic nerve, and the two diaphragm muscles are separately innervated. So if you have one diaphragm paralyzed, you can still breathe, but you will only be effectively using the diaphragm on one side. When the diaphragm contracts and descends, it increases the pressure in the abdominal cavity, which pushes out the lower ribs. So that again helps with inspiration. When we have to recruit the external intercostals, they raise and rotate the ribs, moving them out a little bit, increasing space and decreasing pressure in the thorax. And then again, the accessory muscles, which are the sternocleidomastoid and the scalenes in the neck, pull up on the clavicle, the upper ribs, the sternum, and again increase the space inside the thorax and decrease pressures. So if we decrease intrathoracic pressure and decrease alveolar pressure, air is going to move through an open glottis into the lungs. When it's time to expire and the diaphragm relaxes, the elasticity of the lungs cause them to spring back, to get small again. Sort of like if you stretch elastic and then let go, you get elastic recoil. It's passive, everything gets smaller. And if the glottis is open, when that's happening, air leaves the lungs because pressures have gotten higher in the thoracic space. But during exercise and other times when we are actively expiring, if I tell you to breathe out as hard as you can, breathe in and then breathe out as hard as you can, you will feel your abdominal muscles contracting, and they push the abdominal muscles inward and up against the diaphragm, further pushing it up, and again increasing pressure, assisting expiration, along with the return of the ribs to their normal position via elastic recoil. They can also be pulled down further by the internal intercostals. And all of these things increase intrathoracic pressure, which increases alveolar pressure, which causes air to flow out of the alveoli through the airways and back into the environment. So I said that if we are considering at rest with the glottis open and no air movement taking place, just everything at rest, there is no difference in pressure between the outside and the inside, and we're going to call that zero. And it's changes in pressure within the thoracic cavity that cause air movement. And those changes are an increase in pressure, positive relative to the outside during expiration, and therefore air moves from the higher pressure to the lower pressure through an open glottis, and negative during inspiration, causing air to move in. At rest with the glottis open, it's really zero. At rest with the glottis closed, we're sitting a little bit negative. Now, the pressure in the intrathoracic cavity has a somewhat wider deflection, but by the time those pressure changes are seen in the alveoli, they're very tiny. So it's only the difference between about +1 and -1 centimeter of water that is causing this bellows motion and inspiration and expiration. So during inspiration, so the pressures in the alveoli don't vary a lot, just between about positive and -1 centimeter of water. So during maximum inspiration, the pressure is about -1. When you have inspired all the way and open the glottis, the pressure is zero. There's no further air movement. And then during expiration, air is expelled with a pressure that increases to about 1. And at the end of expiration, again, glottis open, no air movement, pressure is 0. Now, one of the things that is important in understanding the lungs is a concept called compliance. And I think I would use stretchiness as a lay term to indicate compliance. If you think about a balloon has a lot of elasticity, but particularly a new balloon doesn't have very good compliance. It's rather hard to change the volume. You need a high change in pressure to change the volume. Once the balloon has been stretched out somewhat, it is more compliant and you don't need as high a change in pressure to change the volume. And lung compliance can be altered by disease. So there are certain lung diseases in which scarring of the lung occurs. They are called fibrosis. The pneumoconioses, like black lung disease, cause fibrosis. There are some autoimmune problems that cause fibrosis. And when that happens, the lungs become stiffer and less compliant. Edema during, for instance, congestive heart failure causing pulmonary edema, or also edema as a result of inflammation in respiratory distress syndrome. Edema also makes the lungs less compliant, and this is relevant when we're thinking about using a ventilator and the settings, how much pressure it's going to take to push a certain volume of air into the lungs. Some diseases decrease compliance, and the most notable one is emphysema. During the course of emphysema, you get loss of alveoli and alveoli merging into bigger sacs that are called blebs, and the lungs lose a lot of their elasticity. There's less recoil, um, and an increase in compliance. So it takes less pressure to get air in, to get a certain volume of air in. And one of the things that you'll notice when you are studying lung diseases like emphysema is that in emphysema, the on a chest x-ray, the lungs appear hyperexpanded, and that's because of this change in compliance. There, again, kind of coming to, there's a lot of physiology that is pretty quantitative that I am not making you learn. But I do want you to understand that lung compliance changes even with each inspiration or expiration. And there's something called a pressure volume curve. And as you begin to inhale and your intrapleural pressure, which is considerably lower than the intraalveolar pressure. So intrapleural pressure in centimeters of water might get to -20 or -30. That as you inhale, decreasing pressure, increasing volume. There is this curve is further to the right, and it takes a larger increase or decrease in pressure to change volume. And when you exhale, the opposite occurs, moves the curve to the left. One of the things that is also shown in this diagram is that if you think about the lungs functioning in a environment where they are upright and being acted upon by gravity, the pressures within that intrapleural space, the intrathoracic pressures, are different at different points in the lungs. They are more negative at the apex, at the top, and the alveoli are actually more expanded. And they are less negative when you get to the base of the lungs, just over the diaphragm, where the alveoli are smaller and are not going to increase in volume as much during an inspiration. So if compliance is stretchiness, elasticity is the ability of the tissue to return from a stretched state back to the original state. And there are two proteins that contribute to elasticity. They are collagen and elastin. They are cross-linked and kind of knitted together in a way that's very similar to a nylon stocking. So when you think about it, if you take a single thread of nylon, an example might be a very fine gauged fishing line, and try to stretch it. It doesn't stretch very much. But if you knit filaments of nylon into the conformation of a nylon stocking, then the geometry, even though the fibers themselves aren't stretchy, they're stiff, the stocking itself is very elastic. And when you stretch it, it stretches easily, it's compliant, but when you let go, it returns to its original conformation. So it's also elastic. In addition to the collagen and elastin fibers that are in that basement membrane made by the fibroblasts, the type 2 alveolar cell, or I guess it's type 1 alveolar cells, the structural cells, um, it, there is a substance called in addition to the sorry, my dog is chewing up something. Oh, something bad. You are so bad. Lala is chewing up my pencil sharpener. Let me pause. So, in addition to the elasticity that is created by these proteins and their knitting together, essentially cross-linking, is that there's surface tension of the fluid, the water, that is on the inside of the alveoli. That surface tension is somewhat reduced by a substance called, boy, I'm having a brain fart, sorry, surfactant. But there's still significant surface tension, and that contributes to the elasticity of the lungs. So, what is surface tension? It is a force across the distance, a distance on the surface of a fluid. And it's what keeps bubbles from forming and being stable in just plain water. If you lower surface tension using things like soap and detergent and agitate the water, you can get stable bubbles. In after World War I, when the first chemical warfare agents like chlorine and mustard gas were used, physiologists doing research on animals exposed to those gases developed pulmonary edema and were coughing up fluid. And a physiologist noticed how stable the bubbles were in this fluid, that this foamy fluid that was being coughed up by the animals with pulmonary edema as a result of their gas exposure, and found a substance that was named surfactant that has similar characteristics to soaps and detergents. It increases the stability of the alveolus. It increases compliance. It decreases the elasticity somewhat, and it also reduces pressure around the capillaries in the wall of the alveolus, which decreases the chance of alveolar edema. Less surfactant or lack of surfactant results in, among other things, difficulty expanding because of decreased compliance and increased pulmonary edema. And in fact, that is the cause of a syndrome in neonates kids who are born prior to making enough surfactant that is infant respiratory distress syndrome. I mentioned earlier that the pressure in the lung, in the intrathoracic cavity and in the lung, is not equal in throughout the lung because it has weight and it is subject to the forces of gravity. So the pressure at the bottom of a lung in the pleural cavity is less negative than it is at the top. And we divide those areas of a lung into three zones called the zones of ventilation. Zone 1, Zone 2, and Zone 3. Zone 1 being at the top and Zone 3 being at the bottom. As we inhale, because pressures are more negative at the top, those alveoli increase in size more greatly. The alveoli at the bottom tend to stay smaller because of the left. But okay, so the alveoli at the top, let's start this over. There are three zones of ventilation. Um, Zone 1 at the top, where the pressures are more negative, Zone 2 in the middle, and Zone 3 at the bottom, where the pressures are least negative. Now, during an inhalation, the smaller alveoli at the bottom are able to increase in size even more, and so more air ends up moving into the relatively lower pressures but smaller alveoli at the bottom of the lung. And the opposite is true at the top, that at the apex, while the alveoli are a little bit larger because the pressures, the intrapleural pressures, are a little bit more negative, but when you inhale, because they start larger, their increase in volume is smaller during inspiration. So we move more air, considerably more air, in zone 3 with the smaller alveoli, even though the pressure is less negative. Now, we've talked about how there is ventilation and there is perfusion or blood flow. And we talked during the cardiovascular lecture about how pulmonary blood flow, well, we didn't talk specifically about pulmonary blood flow, but we talked about tissue blood flow being regulated primarily by things happening locally in the environment. And there are some local factors that regulate pulmonary blood flow. In an area of the lung that is not being well ventilated and becomes hypoxic, vessels will constrict. Think about this, that you're having your snack of peanuts and you toss a peanut and accidentally inhale it, and it goes straight down into your right lung, blocking a segment of lung. And so as you breathe, that segment of lung is not going to be getting air, and the air in the alveoli is over the course of seconds to minutes it's going to continue to lose oxygen until it becomes quite hypoxic. All the oxygen gets used up, and that hypoxia causes local vasoconstriction, which prevents blood flow to the area that's not getting ventilated. And this prevents a mismatch of ventilation and perfusion. The blood gets rerouted to areas of the lung that are getting ventilated. we're going to talk a little bit about how breathing is regulated, and here we're getting into kind of serious physiology. As you can imagine, the regulation of breathing and of gas levels is really important. So there are a lot of mechanisms to maintain our oxygen levels, partial pressure of oxygen and partial pressure of CO2, at about the same rate, no matter what we're doing. So if you are sitting in a chair versus taking a brisk walk, if you had blood gases checked in both of those circumstances, they wouldn't be very different at all. And that's because even though you may be breathing quite differently, it's the regulatory mechanisms to maintain homeostasis that keep the blood gases the same. And it's very tightly controlled. So, we're going to talk about some of the things that control breathing. And we'll come back to some of these. In fact, I think we'll come back to all of them. The first are chemoreceptors. There are receptors that detect certain chemical changes. They're, they exist in both the periphery and centrally in the central nervous system. There are receptors in the lung that detect movement and stretch. All of these things send signals to respiratory control areas in the brain stem, specifically in the pons and in the medulla oblongata. Those signals that are processed in the breathing centers send signals out to the muscles of respiration and tell them how hard to work. So, when we are, for instance, increasing activity, say running, instead of only using the diaphragm for inspiration, we're going to bring in the intercostals and the accessory muscles. If we are having difficulty with obstruction, say an asthma attack, and having difficulty exhaling, these signals are going to recruit the uh, expiration accessory muscles and the abdominal muscles. And these all work with negative feedback loops. One example is sleep. When you fall asleep, you breathe less. Your breathing becomes slower and shallower. And because you're breathing less, you're exhaling less CO2, and your PCO2 goes up a little. The chemoreceptors, and we'll talk about which ones, but chemoreceptors at a couple of sites will send signals recognizing that there's an increase in PCO2 to the pons and to the medulla, to those respiratory centers, which will cause outgoing effector signals to muscle to increase the rate and the depth of breathing. And when that happens, arterial PCO2 will go down. So, where are these receptors? Well, some of them are central and some of them are peripheral, as I said before. There are chemoreceptors in two places peripherally. One is in the aortic arch, very close to the baroreceptors that we talked about being involved in the renin angiotensin, well, in volume control, sorry, not particularly in that system, but they're involved in that system and in other systems. So, baroreceptors that detect changes in pressure are very close in the aortic arch to chemoreceptors. The peripheral chemoreceptors can detect three things. They can detect a change in oxygen levels. They fire with a decrease in oxygen. They can detect changes in CO2 levels. Their firing increases with an increase in CO2. And separately, they detect changes in pH, in the hydrogen ion concentration. So if hydrogen ion concentration or goes up, which means pH goes down, it triggers peripheral chemoreceptors. As I said, there are two sites, and the other site is at the carotid bifurcation in something called the carotid body. And there are also baroreceptors there. So baroreceptors and chemoreceptors are living in kind of close proximity in those two places. And in humans, the carotid chemoreceptors are more important. But there are chemoreceptors at both sites. They send signals to the pons. There are also chemoreceptors in the brainstem that we call central chemoreceptors. We'll come back to talk a little bit more about them. They're a little different than peripheral chemoreceptors because they recognize changes in CO2. It says in hydrogen ions, but that's indirectly, and I'll come back to that. So the peripheral chemoreceptors primarily are recognizing changes in oxygen level, changes in CO2 level, and changes in blood hydrogen ions. The central chemoreceptors are recognizing changes in hydrogen ions as a result of increased CO2. Other receptors include um, receptors in the nose that can be irritated. There are there are signals that can be sent by the hypothalamus in response to emotional stimuli and pain. And here I think this is representing the hypothalamus. There are a lot of receptors in the lungs themselves that detect stretch, that detect irritants. There are receptors in the muscles and joints. Um, and all of these receptors are sending information, and the cortex, higher centers, because as you know, you can voluntarily control breathing to a point. You can slow your breathing down or speed it up. You can make yourself hyperventilate to a point. So all of these centers, the hypothalamus, the higher centers, the receptors in the lungs and in the periphery, and central receptors, which are local, and muscle and joint receptors, all that information is getting sent in to the pons and medulla where the respiratory center is. There are some rhythm controllers or pacemakers in the brainstem. There's something called the pre-Botzinger complex. You don't have to memorize all of this stuff. But in the medulla, there's a pacemaker, a rhythm generator. And then two groups of neurons that are associated with inspiration and expiration. And in the pons, there are centers that are excitatory to increase rate and rhythm and inhibitory to decrease rate and rhythm. So all of these neurons are connected and working together to control rhythm and depth of breathing. And here we're showing those control centers in the pons and the medulla. The pre-Botzinger complex, which is basically the pacemaker, the dorsal and ventral respiratory groups, and the inhibitory and excitatory cell groups in the pons. These are these are the areas that are getting input from all of these receptors and other sources like the hypothalamus and the cortex. And then they are sending out effector signals to muscles to control breathing. The phrenic nerve, when it's firing and getting um, more frequent action potentials, um, we inspire. When those impulses die back, we expire. And remember that each diaphragm is separately controlled. There are two phrenic nerves, which is a very good thing. I mentioned that the cortex can exercise voluntary control. So you can make yourself hyperventilate to the point where you drop your arterial CO2 quite low to half of its normal level. Doesn't feel very good, but you can do it. Trying to stop breathing doesn't work nearly as well. Things are triggered that make you breathe. The hypothalamus, as I said, responds to things like emotional changes in pain, and so does the limbic system. So when we get terribly upset, our breathing can be quite affected by that. When we're hurting, our breathing is affected. I'm going to come back to the sensors. So we have central chemoreceptors that are in the brainstem, and they respond to a specific change in the extracellular fluid in the brain. And that is a change in hydrogen ion concentration as a result of higher CO2. The peripheral chemoreceptors in the aortic arch and carotid bifurcation, carotid body, detect changes in blood oxygen, blood CO2, and hydrogen ions. And then I mentioned that there are stretch receptors in the lungs, irritant receptors in the lungs and in the nose that have input into breathing, and then the receptors in the muscles and joints. So I want to talk in somewhat more detail about chemoreceptors. And I've kind of danced around this a little bit, that the central chemoreceptors, they're part of the brain, they're part of the central nervous system. They're in the ventral medulla, and they detect changes of pH in the brain's extracellular fluid, essentially the same fluid continuous with cerebrospinal fluid. And they're responsible for most of the minute by minute control of respiration, not the second by second, breath by breath control, but minute by minute. If you think about the blood brain gas barrier, or the blood brain barrier in general, there are things that can cross it and things that can't. It consists of plasma membranes, and so gases easily diffuse, oxygen and carbon dioxide. So carbon dioxide levels that are high easily diffuse across those membranes and equilibrate in the brain extracellular fluid and in the plasma and in the CSF. So it's all the same. But ions don't easily cross that barrier. And so you don't get movement of hydrogen ions and bicarb across that blood gas barrier. So if systemic pH goes down, the hydrogen ions don't diffuse. If you get acidotic, the hydrogen ions don't make it across easily across that blood gas barrier. But the CO2 does. And if you remember, CO2 dissolved in water makes carbonic acid, H2CO3, which then dissociates into hydrogen ions and bicarb in the brain's extracellular fluid, interstitial fluid, CSF. And so while the hydrogen ions from high CO2 don't cross out of the plasma into the brain, the CO2 does. And there's not a lot of buffering in the CSF. So very small changes in the CO2 that is diffusing into the brain will cause hydrogen ions to be formed that will trigger the central chemoreceptors. It's important to remember, I should have made this in red, but central chemoreceptors do not respond to oxygen levels, not at all, not a little bit. It's CO2 by virtue of CO2 um, creating hydrogen ions when it's dissolved in water. So, blood pH doesn't affect chemoreceptors. Oxygen levels don't affect central chemoreceptors. Only CO2 and the hydrogen ions that are made inside the brain when the CO2 is dissolved in water dissociates. So, what happens when somebody is chronically hypoventilating? This could be somebody uh, in a coma who does not breathe effectively and is chronically hypoventilating and has high CO2 levels. It is very common in people with severe chronic obstructive pulmonary disease. They can't get their air out, and CO2 levels tend to go up. So they have chronically high blood levels of CO2. Well, the choroid plexus that makes CSF responds to those increased CO2 levels by adjusting the pH of the CSF to keep it normal. And so you don't get the increase in ventilation that you might expect if there were an acute change in carbon dioxide. We're going to talk a little bit about the peripheral chemoreceptors. So remember that some of them are in the carotid body near the baroreceptors in the carotid body. Those ones send their signals through the ninth cranial nerve, the glossopharyngeal nerve. There are also peripheral chemoreceptors in the aortic arch, also near baroreceptors. Those signals are sent by the 10th cranial nerve or the vagus nerve. So similar locations to baroreceptors. And of interest, baroreceptors in very extreme conditions, very low oxygen, very high CO2, the baroreceptors can be chemoreceptors as well. They can be activated or triggered. The more important of our peripheral chemoreceptors are the carotid body chemoreceptors. And unlike central chemoreceptors, they respond to arterial oxygen levels, so the arterial partial pressure of oxygen. A clinical point here is that in carbon monoxide poisoning, where the oxygen on hemoglobin molecules has been displaced, there is still a normal partial pressure of oxygen, and we don't get a signal from these chemoreceptors to increase breathing because they're not detecting the low oxygen carrying capacity of the blood, just the partial pressure of oxygen, which is normal. And so little changes in oxygen level don't cause big effects under normal conditions. When oxygen levels are quite low, partial pressure of oxygen, so when you're at a high elevation, these chemoreceptors become more sensitive and there's a larger response. And the carotid body chemoreceptors, like the central chemoreceptors, do respond to changes in PCO2, in CO2 levels of arterial blood, which is not what the central chemoreceptors are responding to changes in in CO2 in the in the interstitial fluid, the extracellular fluid, the CSF. The carotid body peripheral chemoreceptors are responding to CO2 levels and pH of arterial blood. And they're not nearly as sensitive, but they're faster. So if you hold your breath for a couple of seconds and increase PCO2 and hydrogen ions, you're going to have signals that will make you breathe relatively quickly. We talked about the other receptors. There are stretch receptors in the walls of the airways that respond to an increase in lung volumes and that keep you from over expanding your lungs. You can only breathe in so far. There are what I talked about irritant receptors, and they respond to things like smoke, particulates, cold, sometimes overstretch. They have a role in asthma, and they tend to cause bronchoconstriction. There are other receptors, J receptors and C fibers, that aren't completely understood. So you don't have to, I wouldn't ask you a question about those. In addition, I mentioned irritant receptors in the nose. The receptors in joints and muscles, when you are exercising, your joints and muscles are sending signals to increase ventilation. There's something called the gamma system that is involved in the sensation of dyspnea. There's an S missing there, a shortness of breath. I mentioned arterial baroreceptors, pressure receptors, can also play a role in the control of ventilation, and pain and temperature receptors. And they would be acting through the hypothalamus or through the cerebral cortex. There are relationships between the response to the partial pressure of oxygen and the partial pressure of carbon dioxide. And as we decrease oxygen, particularly say at high altitudes, move this curve to the left, you get a much bigger response to changes in carbon dioxide. And it's carbon dioxide levels primarily that control the levels of ventilation, and there are a lot of things that can affect that. So, for instance, deep anesthesia, carbon dioxide levels can get very high, but we are impairing the ability to increase ventilation. Same thing is true for narcotics, less so for sleep. Metabolic acidosis, on the other hand, if we have high levels of hydrogen, we get an even sharper rise in ventilation as a result of changes in kind of minimal changes in CO2 levels. So our response to carbon dioxide is altered by sleep. It is altered by age. The older we get, the less well we respond to changes in carbon dioxide levels. There are genetic factors. Training, exercise consistently has an effect. And then chronic obstructive lung disease, which increases the work of breathing, can ultimately change our response to carbon dioxide levels. So, remembering that the peripheral chemoreceptors respond to the partial pressure of oxygen, one of the interesting things that we see in physiology is that there are connections between the response to oxygen and to carbon dioxide. So, when oxygen levels decrease significantly, for instance, at high altitude, the receptors respond even more strongly to changes in PCO2. In some patients with chronic obstructive pulmonary disease, so bad COPD, who have chronically low oxygen levels, and in these folks, they tend to be the same people who develop chronically high CO2 levels. So there's hypoventilation, low oxygen levels because of mainly loss of alveoli and absorbing capacity, high CO2 levels because of the inability to effectively get the CO2 out and exchange that gas. These folks have a very finely tuned drive from minor changes in oxygen levels. So their respiratory drive is driven more by changes in oxygen than by changes in CO2 because the CO2 levels are so chronically high that we've kind of banked down our response to them. In these people who have primarily oxygen driven ventilation, if you give them oxygen, supplemental oxygen, you can actually turn off their drive to breathe. So this happens in these folks who sometimes are sort of on a knife edge and they have a little cold, an exacerbation, their oxygen level drops some, they're short of breath. They call 911, and in the ambulance, they're given oxygen because they're short of breath. Well, a savvy provider, paramedic, EMT, PA, doctor, nurse practitioner, knows that in these folks, supplemental oxygen has to be controlled. You can't just put on a face mask at 100% because if you do, they simply quit breathing. So we give these folks just a little oxygen, maybe 2 liters, enough to bump up their uh, oxygen saturation by a little bit without knocking back their drive to breathe. Blood pH is sensed by peripheral chemoreceptors, so high hydrogen ion levels. If you remember, I said central chemoreceptors, while they're responding to hydrogen ions, are not responding to blood pH, only to the hydrogen ions generated by high CO2. This response is important in some conditions that we call metabolic acidosis that include things like aspirin toxicity and much more common diabetic ketoacidosis. When pH is very low, we we seriously trigger the peripheral chemoreceptors. Eventually, if it's very bad, we might trigger some central chemoreceptors. But what happens is that change in pH with the high hydrogen ions tends to trigger increased ventilation. It's as if the body is trying to get rid of more CO2. And in fact, that's what's happening. This is one of the ways in which the lungs help to regulate pH. When hydrogen ions are high, peripheral chemo receptors detect that, increase ventilatory drive, making you breathe more deeply, more frequently, getting rid of more carbon dioxide, which ultimately affects pH by having less carbonic acid and fewer hydrogen ions. We don't have a clear understanding of why we breathe harder when we're exercising. We know that the blood gases don't change. If you draw blood on somebody who's vigorously exercising, it's not much different than somebody who's sitting in a chair reading a book. And the pH doesn't change much. There are some extreme conditions, people who are long distance runners where they might develop some lactic acidosis, but in general, not a big response. So we think that probably the increased breathing in exercise comes from those receptors in muscles and joints that are detecting increased movement, along with cortical signals, possibly increase in generated heat, so a small increase in temperature. And we think there may be a reset of the carbon dioxide reference level during exercise because when we're breathing heavily during exercise, we're actually breathing off a little bit more carbon dioxide. Sleep apnea is a condition that's quite common. There are two kinds, one of which is obstructive, and that's the common one. That is sleep apnea resulting from excess tissue in the pharynx. So big tonsils and maybe a floppy, soft palate and uvula. It's more common in people who are obese It can cause snoring. And its effects are that these people, when they fall asleep and the tissue obstructs, they quit breathing. It wakes them up so that they're never sleeping very soundly, and they have daytime somnolence. They may have difficulty with performing cognitive tasks. They may have accidents, and this is not an uncommon cause of motor vehicle accidents with people actually falling asleep or losing their attention at the wheel. The second kind of sleep apnea is central, and it's different. So, with obstructive sleep apnea, we have an obstruction, the person quits breathing, their uh, chemoreceptors, particularly their peripheral chemoreceptors, detect a reduced oxygen level, an increased CO2 level. They trigger an increase in breathing, which often wakes the person up. They breathe, they fall back asleep. It's repeated through the night. With central sleep apnea, though, triggering of those receptors doesn't do anything. So, in people with central sleep apnea, when they are sleeping, they just lose their drive to breathe. I want to talk a little bit about something that I find counterintuitive. When we were talking about flow in blood vessels and laminar flow, we said that blood flowing through straight wide vessels develops laminar flow. And that's the straight wide vessels where the blood is traveling at a rather rapid rate. But in the lungs, it's quite different. And this is because primarily air is very low viscosity compared to blood. And in the lungs, laminar flow tends to occur in the parts of the lung that air moves very slowly. And that, if you remember, is the respiratory zone. So the tiny bronchioles have laminar flow. And flow is sensitive to the diameter of the tube, right? So the smaller the tube, much more the smaller the flow. Long, smooth tubes like the trachea and the main bronchi tend to promote turbulent flow. So it's interesting that it's quite different in air moving through breathing tubes than it is blood moving through blood vessels. I want to talk for a minute about a concept called shunt. A shunt occurs when blood is rerouted from the venous system to the arterial system so that it doesn't have a chance to exchange gases. There is a small, what's called physiologic shunt, that includes the blood that that provides nutrition to the bronchi, so that second lung circulation, the bronchial blood flow, and then the coronary arteries, which return deoxygenated blood directly into the left ventricle. So the venules from the coronary artery flow return the blood into the left ventricle. So that's a very tiny physiologic normal amount of blood, about 2%, that doesn't get a chance to pick up oxygen. But there are some non-physiologic shunts. So some of the congenital heart conditions, like tetralogy of Fallot, include shunts where deoxygenated blood ends up in the systemic circulation. It can happen in different ways. In tetralogy of Fallot, there is, among other things, a VSD, in which blood from the right ventricle that is coming in through the venous system enters the left ventricle and is mixed with oxygenated blood, so that you get only partially oxygenated blood going out through the aorta. There are other abnormalities in tetralogy of Fallot. There are four specific abnormalities. But because of the way the aorta is shifted, the obstruction to right ventricular outflow, and most particularly the ventricular septal defect or opening between the ventricles, we get some deoxygenated blood getting sent straight into the circulation, and these babies are blue. They can survive for a while, but they don't thrive until this is fixed. They are given, if they are given oxygen, it doesn't help because there's still deoxygenated blood mixing with oxygenated blood. There are left to right shunts in which blood is moving from the oxygenated side to the deoxygenated side. So something called patent ductus arteriosus, which is a congenital issue where the a duct that bypasses the lungs during fetal development doesn't close, and blood now getting pumped on the left out of the left side is getting pumped back into the right side because pressures are higher on the left than on the right. And that's true of most ventricular septal defects. It's different in tetralogy of Fallot. But in most VSDs, the pressures on the left side are higher, so oxygenated blood is getting mixed with deoxygenated blood as opposed to the other way around. But in the lungs, sometimes it can happen that we have an area of the lung that isn't being well ventilated. And in this case, it's showing alveolus that has pneumonia, that's full of pus and fluid, and where we don't have a good partial pressure of oxygen because we have a lot of fluid there. And in that case, the deoxygenated blood that is passing through this part, through this acinus, this consolidated acinus, is not getting oxygenated. And it is then getting mixed back in to the blood that has been oxygenated from a ventilated alveolus. So in the case of a portion of the lung that is not receiving is not allowing appropriate oxygen exchange, you can get a shunt effect where the PO2 and the blood returning to the right side of the heart is low. I mentioned earlier that gravity affects the pressures in the lung, particularly when I was talking earlier, we were talking about the pressure, the size of the alveoli and the expansion of the alveoli, but it also affects pulmonary blood flow. You remember that zone 1 at the apex of the lungs, zone 3 at the base of the lungs. And in zone 3, there is normal blood flow. The capillaries stay open all the time. But in zone 1, it's possible that alveolar pressures are higher than arterial pressures and can compress the vessels, leading to a situation where there is ventilation but not perfusion. There are also these differences in ventilation. So intrapleural pressure is higher or less negative at the bottom than at the top. The alveoli are small at the bottom, but they're better able to increase in size with inspiration. And at the apex, they're bigger, but they are less able to increase in size with inspiration. And so coming back to that concept that we called the VQ ratio, V being ventilation, Q being blood flow. As I said earlier, it's close to 1. And in fact, it ends up being more like zero point 0.8, but that's close enough to 1, where the amount of blood flowing through the lungs in a minute is very similar to the amount of air flowing through the lungs in a minute. It's highest in zone 1 because in zone 1, ventilation exceeds perfusion, and it's lowest in zone 3 because in zone 3, perfusion exceeds ventilation. And I believe we're close to the end here. Surfactant, I mentioned earlier, is a substance that's produced by cells in the alveoli, and it is continuously produced after about 30, I think 32 or 33 weeks of gestation. So premature babies sometimes can't make sufficient surfactant, but once you can make surfactant, you make it all the time. If something interrupts the production of surfactant, then the surface tension of the fluid in the alveoli increases, which it pulls the alveolus into a tighter, smaller space, and it increases the stiffness of the lung. That means it decreases compliance, and it creates a tendency to pulmonary edema. And so in our current time with COVID-19, I suspect that one of the issues causing pulmonary edema and increased compliance and inability to ventilate with the respiratory distress syndrome that occurs with COVID, as it does with many other conditions, is this increase in compliance as a result of ineffective surfactant. This is a slide that I almost took out, but I just kind of wanted you to understand that there is a relationship, I think we talked about this earlier, between pressure and volume in the lungs. And if we look at lungs that are normally compliant, this curve is a little different with inspiration and with expiration. And that compliance is a little higher with expiration. So we get a bigger volume change at a lower pressure. Whereas lower pressure change. With a lung that is being inflated and deflated with saline, compliance is much lower, and there is no hysteresis. There's no difference. Is compliance lower? Let me go back there. I almost took this slide out, but it's just illustrating that pressure volume or compliance curve again, that and showing that in normal air-filled lungs that there are changes in compliance as we inflate, inhale, and deflate, and that there is some difference in compliance curves during inspiration and expiration. Whereas in lungs that are filled with saline, there is a much sharper increase, and there's no difference during the injection of the saline and the removal of the saline. This is showing a diagram of somebody hooked up to a spirometer having pressures measured during the breathing cycle. And I talked about this a little earlier, but I want to show you now that how pressures change during inspiration and expiration, and how the intrapleural pressure changes quite a lot. It drops down to about -8 centimeters of water during inspiration, gets back up close to 0. Here it says -5 with expiration, while the alveolar pressures are only varying by about 2 centimeters of water, down to about -1, up to about +1. You can see that the flow curve in liters per second almost exactly matches the pressure curve, and how here we have volume increasing. That doesn't seem right, but that's true, and then decreasing. It's just that they've got that curve upside down, don't they? And resistance in the breathing tubes is different, again, than in the vasculature. If you remember, the site of greatest peripheral resistance in the vasculature is the very small vessels, the arterioles. But because of the very large number of small airways and the laminar flow at slow flow rates in the small areas, resistance in the lungs is very low in the bronchioles and terminal bronchioles, and is higher in medium-sized airways. As we increase lung volume, we're kind of pushing open the tubes, and that decreases airway resistance. So as we inhale, we are decreasing airway resistance. Airway resistance increases when we exhale, which is why obstructive diseases like asthma and COPD, it's typically harder to exhale than it is to inhale. The airways are tethered, the little bronchioles, by the alveoli, and as the lung is expanded, the airways are pulled open. And the blood vessels are also pulled open, not the alveolar capillaries, but the blood vessels around the acini, improving blood flow. Now, I mentioned that COPD, or chronic obstructive pulmonary disease, causes obstruction to airflow, obviously, or it wouldn't be called obstructive pulmonary disease. Most COPD results from smoking, but there is an enzyme deficiency, an inherited genetic abnormality called alpha-1 antitrypsin deficiency, that can also cause emphysema, even in people who never smoked. Emphysema, I have that misspelled, I apologize. Because of the problems with airway resistance in COPD, these patients tend to maintain high volumes in their lungs, and in fact, over time, their chest walls remodel so that they have what's called an increased AP diameter. They're wide from front to back, and this is a compensation to the resistance to expiration in the airways. By having bigger, more inflated lungs, it reduces resistance a little bit. Something that some people with COPD figure out for themselves, and some can be taught, is that when they expire, if they expire against pursed lips like this, it increases expiratory pressure in the airways and therefore in the alveoli, and that helps to keep those airways from collapsing. So pursed lip breathing is a tool that can help patients with COPD. Asthma is another obstructive disease. And in asthma, the airways are quite reactive. So the bronchial smooth muscle in the small bronchi and the bronchioles that is controlled by the ANS, but also has other inputs, some of them environmental, some of them internal. During asthma, those airways constrict, and that increases the work of breathing, tends to cause air trapping, makes it more difficult to expire. This obstruction is reversible, but it's worse in expiration because those narrow airways further collapse as the pressures in the intrathoracic cavity increase during expiration. We treat asthma, one of the main treatments of asthma is with beta 2 adrenergic agonists, so that by triggering those beta 2 adrenergic receptors, we can increase the diameter of the airways and decrease resistance. Back in the old days, I don't know if you can even still get this, but when I was a kid, people with asthma used something called primatene mist, which was basically epinephrine in a mist. And the epinephrine, which is a non selective beta 2, beta 1, alpha 2, it's a non selectic adrenergic agent, it would help decrease airway resistance, but it would also do everything else that it does, like constrict vessels and increase heart rate. And so it was a drug that had some good effects, some adverse effects, and was not optimal. So the development of albuterol, which is more selective, was very helpful for people with asthma. There are other factors than autonomic nervous system input that can cause airway constriction. So the airways constrict by reflex when there's smoke, when smoke is inhaled. In some people, in response to cold air, those irritant receptors can be hyper reflexive and cause constriction. Inflammation from allergy or from infection can cause airway constriction. And this last point has nothing to do with asthma, but it's the last point, so I didn't put it on its own slide. The density of the gas that's being breathed affects the airway resistance. And if you think about it, a scuba diver who's down well underwater where there are external pressures on their thoracic canals, it is much harder for them to move gas, to breathe. There's a lot more resistance. And so scuba divers often breathe a mixture of helium and oxygen to have an easier time breathing, get less tired out, because this is a less dense gas mixture, and therefore the work of breathing is easier. So that's it for this lecture, and we will likely have a quiz.